Good afternoon, and thank you so much for joining us today at this event. We're just letting some people into the room before we start. But just as an introduction, my name's Dr. Mary-Anne Farrow. I'm a medical director at Kent, Surrey and Sussex Academic Health Science Network, and I'm also an associate NED for Kent and Medway Social Care Partnership Trust, which is mental health. Really pleased to be chairing this event today. We have some fantastic speakers who will be talking about, this really important issue. Just a few little housekeeping things. So please note that this session is being recorded, and please use the chat box function. Really keen to hear your thoughts, your comments, your questions. And we'll have plenty of time to enable some of that discussion as well. If you can keep your cameras on wherever possible, that would be great. If you lose connection, please rejoin using the link. Ensure your microphone is muted during the presentations. We just want to minimize some of that background noise. Obviously, we welcome questions from each of the speakers, and you can post those into the chat function. And if we do come to you to ask questions, then please make sure you speak really clearly, you raise your hand, and we'll bring you in. Any unanswered questions, don't worry, we'll get back to you with an answer after the event. And of course, please make sure you fill in the evaluation form at the end. We really appreciate your feedback. So, just in terms of some background, NHS Providers is a membership organisation for trusts and foundation trusts, helping them to deliver high quality, patient-focused care by enabling them to learn from each other, acting as their public voice and helping shape the system in which they operate. This event will allow delegates to hear from NHS leaders on solution-based interventions that have been implemented by trusts for their local communities. This is in response to evidence disparities with a focus on improving their health outcomes. And this event has been developed based on the insights from white and ethnic minority trust leaders. So from these insights, we've identified that there are three key areas for meaningful change on race equality. And these are changing hearts and minds, giving leaders the confidence and capability to act through evidence of what works, and asking leaders to take accountability for embedding race equality at the heart of boards' business. So as I mentioned today, we have some fantastic speakers, and you're going to hear today from Kathy McLean, who is the chair of University Hospitals of Derby and Burton, Jenny Lewis, Director of HR and OD at the Leeds Teaching Hospital for NHS Foundation Trust, Michelle Stanley, Head of Leeds One Workforce, Leeds Health and Care Academy, Rob Aitchinson, Deputy Chief Executive of Calderhay and Huddersfield NHS Foundation Trust. So moving on, we're going to be hearing a presentation from Kathy McLean. And as I mentioned before, you'll be able to ask some questions at the end. So please make sure you put these into the chat box so that we can pick them up at the end. Over to you, Kathy.
Hello and good afternoon. I'm hoping somebody's going to share the slides. Are you doing that?
Yes, we are, Kathy.
Thank you. If we get those up. So hello, everyone. Yes, I'm Kathy McLean. I'm chair at UHDB. And I want to share with you some things that we've been doing within the trust, but also sort of slightly more broadly across our system. So if we go on to the first slide. So just a bit about the patch that we're in. UHDB is slightly odd in that we have part of our organisation in Derbyshire and part in Staffordshire. So it's a large population that we serve overall. We can see there that there's divided between some counties and also the city of Derby, and a bit of a breakdown there of the different groups. So Derbyshire is more uniform, if you like. 96% would describe themselves as white, but 80% in Derby City, and Staffordshire and Stoke-on-Trent is more similar to the city. So large population. One of the challenges for us is that our money on the whole comes through the Derbyshire system, but also there is some money from NHS England. So it's slightly odd and not quite equitable between our two systems. But if we carry on to the next one. Next slide, yeah. So in terms of our local context for health inequalities, risk factors and outcomes, the main, you can see there's some differences between, as I say, the city and the counties. But the main risk factors impacting on the outcomes for our populations are, as you might expect, cancer, respiratory illness, circulatory disease, alcohol in Derby City in particular. So these are some of the factors that lead to that difference. But the risk factors, if you like, underpinning all of that is, again, probably very similar to many areas: smoking, obesity, hypertension, diabetes, osteoporosis, and depression. And these are significant contributors to the gap in life expectancy, and also lead to the higher number of early death being below 75 years. And if you add in musculoskeletal disorders, they are also, between them, the main contributors to causes of morbidity, in other words, ill health. So you can see there we've got some variation. You can see on the Derby City side, alcohol is a particular challenge, and we've got higher smoking prevalence here. So considerable differences between the various parts of our systems. Next slide. We know that there's a big impact of deprivation, and in terms of how deprived are our communities, Derby City stands out in particular. We've got a significant number of people who are in the most deprived sector, if you like, across the country. And of course, as you know, more deprived areas have a lower life expectancy and a lower healthy life expectancy. So there's a big gap between the two. So in terms of the life expectancy, there are about 22 years of a gap of healthy life expectancy between the most deprived and the least deprived areas. So if we go on to the next slide, what are we doing around some of these things? So across the systems, and they're slightly different, but there's an awful lot of overlap between Derbyshire and Staffordshire, improving the population health. A lot of this is based on tackling those risk factors. So reducing smoking prevalence to below the national average is a key one. Increasing the proportion of children and adults who are a healthy weight, and obviously the alcohol and physical activity. And very importantly, reducing the number of children living in low-income households, improving mental and emotional well-being, but also improving housing standards. We know that makes a significant difference. So the Staffordshire list is quite similar, and we are also looking at improving or enhancing our approach to population health management. So data and analysis of data is really important in all of this. So if we now go on to the next slide, what is UHDB specifically doing? We're working across the systems, obviously working with the local authorities as well, working with what we call the local place alliance groups, which are our name for sort of groups of PCNs, and at the ICS, as I've mentioned, working with the population health management. So we're aiming to impact on people who attend the hospital, who come to outpatients. So there's referrals being made from those scenarios. For example, we've got something called Impact Plus and relating to children's asthma. So when they attend, there's referral directly to housing. For the emergency departments, we have high intensity users, complex gastro patients are referred to local area coordinators. And we also have ENT and vascular outpatients to try and reduce tobacco dependency by making those referrals as well. And then for elective waiting lists, we focus on weight loss and reducing smoking. So if we go on to the next slide, these are some of the things that UHDB is doing. So the Trust is doing directly, focusing within alcohol screening, tobacco dependency treatment, cancer referrals, waiting list maternity. So some of those things are actually live. So the tobacco dependency treatment went live at the beginning of September last year. And there's a dedicated team for alcohol screening for all patients, and that went live around the same time. We're also working with regional teams to develop high impact plans. And as I mentioned, the waiting lists, ensuring that those are also checked for ethnicity and deprivation to make sure there's no variation. You know, are we treating one group more than another? So there's a real appetite within the Trust to try and have an impact on these things, including links with the housing, isolation, poverty, all of those things as well. So there's a huge amount we can do. We have over 1 million contacts every year, and that's a very significant number of possible change points. We're also giving a big focus to maternity. We've got some very ambitious plans around that to reduce stillbirth, neonatal mortality, maternal mortality, and brain injury. We're planning to halve that by 2025. And to do that, we are focusing on our continuity of care teams, particularly in deprived areas. So if we go on to the next slide. So this takes us more into how are we addressing our res inequalities. So this is less about the inequalities of health within the community, more about our own internal inequalities. So on to the next slide. So what we have done is a huge amount of work over the last couple of years on welcoming diversity. Our networks have really blossomed, but we now have launching an inclusive and compassionate culture programme, because we think that's at the heart of good patient care. We've got a robust equality governance structure which links all of the things such as organisational development programmes to try and get this cultural change. And the Inclusion Belonging Plan, which runs from 22 to 25, unites everybody to try and deliver that change and achieve equality and inclusivity. So there's an awful lot that's being done to make sure that everyone takes ownership of this agenda. So there's a lot of work going on with the leaders, the staff networks, diverse representation in decision making. So, for example, having people from diverse backgrounds, making sure that interview panels, and I've certainly personally chaired interview panels where I've had somebody watching to make sure that they can feedback how well did we do that, and that was really helpful actually. We're using diagnostic tools to embed accountability and governance into all of our processes, and it is certainly a journey. We're not there by any means. On to the next slide. So we've also tried to ensure that there is ownership at the division. So it's not just a board or executive or network challenge. It is owned by our divisions so that they have improvement plans and that they own those themselves. We've had a good reciprocal mentoring program. I've been part of 2 cohorts, and we're on to the 3rd cohort now, and that seems to have been really positive. We have a whole program of Allies for Change, which covers a whole range of different protected characteristics. And what we now call, or they've decided to call themselves, the Embrace Staff Network, is what used to be the BME Staff Network, is hugely strong. Its sponsor is the chief exec, and the leads regularly meet myself as chair. And we've got a glass ceiling project for nursing in particular, because one of the challenges that we often get is that people feel that they cannot progress in their careers. So we are actively working on that. Next slide. As I mentioned, the Compassionate Inclusive Leadership is a programme that the Chief Exec and Chief People Officer have been championing and have been launching. That's been through the board. And we are also planning to become an anti-racist organisation. We've got board development happening shortly, and an anti-racism programme for white presenting senior leaders. So this feels an important step, but is not to be taken lightly. And I think we all deeply need to understand what that means. We've had faith tours. I've certainly been to visits, including the Sikh temple, but those are being arranged for staff and leaders so that they can understand more about our local population, which is hugely diverse. And we've also got civility and respect as a pathway to work on within the organisation. Next slide. So what have we achieved so far? Well, one of the things, I've been chair for 3.5 years. When I arrived, the board was, I think, entirely white and dominated by men, but our diversity has increased really significantly now. It looks completely different with a changeover of non-executives in the last month or 2. So we've now got a successful, I would say, representation of our local communities and of our staff. But that has taken 3.5 years, and I've been conscious of it since the minute I arrived, but it has taken some considerable time. We're also increasing the workforce diversity and also trying to encourage the BME colleagues into senior posts, and that is gradually increasing. We're working obviously with the partners across our systems, and we have Project Search, which is around for people with learning disabilities, and we have been securing employment for them within the trust. So lots of things going on there. Next slide. I think that's pretty much it for me, actually. Happy to take any questions. I think that the main thing I would say is that this requires constant attention from the senior leadership. It requires that we think very specifically about our own development, and it cannot be done by one part of the organisation on its own. It has to run throughout. But if the senior leaders don't take it seriously, don't understand it, we are not going to make that sort of progress that we want. Thank you.
Thank you so much, Kathy. Yeah, really strongly agree with you on that last point. Absolutely must be led from the top, doesn't it? If people have questions, please either raise your hand or pop your questions into the chat box. In the meantime, whilst people are getting warmed up, I've got a bit of a question for you, and it's something you mentioned at the beginning of your presentation. So it's around poverty being, a key driver in terms of health inequalities. And, given the current economy, given the financial insecurity that people are under, high inflation, high mortgage rates, what impacts are you starting to see on that for your patient demographics, and also in terms of the strategies that you're trying to implement to address health inequalities has that been impacted by the current climate that we're living in?
Yeah, thank you. I mean, I think we all know this real challenge of cost of living, don't we? And I think it's affecting our patients, but it is also affecting our staff. So I think we are seeing it amongst the patients. I mentioned some of the things that we are trying to do to help with that, and there's a lot more signposting, working more closely with our local authorities to help our patients, but also for staff. There have been things we've been able to do, about providing food banks and a whole range of things that we actually did bring into being. People sometimes need advances on their salary. We make good use of the salary sacrifice approaches. So I think it is affecting absolutely everybody, and in particular those on lower bands of pay. And then, of course, we see that through the population who come to us, and in some instances, I think, end up coming to the emergency department more than they would otherwise have done. And I think it's linked as well to the way treatments are happening and people are having to wait at the moment, and that's having an impact on people's ability to work and feed their families.
Yeah, thank you so much, Kathy. Yeah, it's a really stressful time, isn't it, for people? I can see one hand up. Karen Bliss, would you like to say your question?
Thanks, Marianne. Thanks, Kathy. Really interesting presentation. Thank you. My question really is about the sort of the health inequalities piece, and the impact on health inequalities. It's obvious. It's actually mainly not the NHS that has the impact here, and I'm interested in, as a board, how are you sort of monitoring your impact on the sort of the health inequalities agenda? Because it's something that we're wrestling with as a board, is because we are really keen to play our part and to hold ourselves to account. But what metrics are you using to sort of measure your impact? I know it's really difficult, so I was just really interested in how you sort of grappled with that.
Yes, so I think that in terms of metrics, we're, like everyone else, grappling with that. I think it's quite tricky. What we are doing, and it's only been running really for about 7, 8, 9 months, is our programs around tobacco interventions and those other interventions. So we are able to count those and see how many people have been impacted by that. But in terms of the actual outcomes, I think we're going to have to wait a bit longer to see the benefits. It's slightly easier for us to deal with the groups which we have more of a sort of arm round. So maternity is a good example of where we have a very strong support to people with deprivations, people who have other challenges. So that's slightly easier to see the outcomes. But I think we are struggling, like everybody is, to find the measures that in the short term, medium term and longer term. And a lot of this is around working with the system, the public health colleagues. I think we do know, for example, though, that things like reducing smoking, it's not just preventing people having lung cancer in 30 years. It has a very, very immediate impact. So we can measure the number of people with respiratory illness coming into the trust. And we have seen that change as a consequence of some of the things that we've been doing. And we've got quite an innovative, more virtual out in the community respiratory programme as well.
That's great. Such a good question. Thank you. I might just bring in Margaret Schwartz. I can see your hand is up next.
Thank you. My question is about your reverse mentoring program. I'm impressed that you've had 3 cohorts. We struggle to find the mentors. We have plenty of people who want to be menteed, the entire board and executive team, and the people that have participated have found it extremely rewarding. But what did you do to encourage people to put themselves forward to be mentors?
Yes, we refer to it as reciprocal mentoring. So we moved away from reverse mentoring.
That's nice.
So reciprocal is good. So it's because it's a two-way process, isn't it, really, in all of these things. I think that it's really interesting question, actually, because I am constantly amazed how many people we have got, and we are able to I should imagine when we've done cohort 3, we'll move on to 4, etc. We have got a tremendous, as I say, networks. They are really, really strong. Amazing, actually. We've just launched a flag which has got 108 different countries on it, which the Embrace network helped us to launch. Absolutely amazing, really. But we've also got somebody who leads on inequality, and she is a force of nature, really. She only works part-time, but she seems to sort of get everybody involved. And my last reverse mentor attended the board and sat beside me and everything the other day, and it was fantastic, really, the way that this is actually going. And it is, you know, it is a drip thing, isn't it? Because even if you have a program, it's not that many people. We've got 14,000 staff. You know, it's going to take us some time to get through, you know, the proportion that you might want to. But I would just urge to keep going and encourage people. And we have launch events, we have wrap-up events, we have all sorts of things. And I think, yeah, people just seem to be willing to come forward. It is quite wonderful, really.
Yeah, it's fantastic. I agree. Mentoring is incredibly important. And I think anyone who is able to put their hand up to be a mentor should, if they can. I'll just take one more question. Apologies around the time. Sharon Womer, I saw that you'd put something in the chat box. Would you like to come in and talk about your question?
Yeah, I just find that a lot of the work ends up on my shoulder or Health Inequalities colleagues. How have you managed to kind of socialise the work and get it to be everyone's business, help, you know, spread the accountability and get other people to contribute towards the success of these projects?
Yeah, so another very good question, all very good questions. So I think this is not an overnight job, but I think when you've got a senior executive team, as well as a board who are interested, but an executive team and a chief exec who gives airtime to these things and actively takes part in things, they have every week they have a session. It's online. It's called the 313 for some obscure reason, but I think that's to make it sound a bit odd, at which the top leaders, so about 600 people, are invited. And that's the sort of thing where this is discussed and people are asked to engage in it, and then they can promulgate that further. And we do a lot of communications. We have, you know, websites, newsletters, we have events there. You know, I have a blog that I put this sort of thing in. It's just endless communication, I think, about it, and people telling their story of the impact it's had on them, the pairs of mentors doing podcasts. It's just endless. You have to get your comms people involved as well as everybody else. But the divisional leaders are really important, and they've got involved in co-sponsoring some of the networks as well. So not just the executive, but the divisional leaders are doing that as well.
Thank you so much, Kathy. You know, the questions are coming in fast and furious, but unfortunately we have run out of time for your section. We'll try to hold some of the questions that are on the chat to the end, but thank you so much, Kathy. Really appreciate you coming to present to us.
Thank you very much.
Thank
Bye-bye.
you. So we'll now move on to our second speaker. So we have a presentation from Jenny Lewis and Michelle Stanley. Jenny Lewis is Director of HR and OD at the Leeds Teaching Hospital NHS Trust, and Michelle Stanley is Head of Leeds One Workforce, Leeds Health and Care Academy. Over to you.
Good afternoon, everybody. It's brilliant to see you all. Hello, my name is Jenny Lewis. Not only am I Director of HR and Organisational Development at LTHT, but I'm also the executive sponsor for something called the Leeds Health and Care Academy here in Leeds, which is a place-based initiative. My pronouns are she and her, and I'm just going to hand over to my colleague, Shell, to introduce herself.
Thanks, Jenny. So, hello, I am Michelle Stanley. I'm Head of Leeds One Workforce, and I work within the Leeds Health and Care Academy.
Thanks, Shell. So Shell and I have worked really closely together for about 5 years, and I've asked Shell to present the first couple of slides because we're going to take you through our journey so far on trying to tackle health inequalities from a recruitment perspective. And of course, I didn't join in Leeds until 2018. So I'm going to get Shell to start the story, and then I'll pick up there as part of the ongoing journey later on in the presentation. So over to you, Shell.
Thanks, Jenny. Next slide, please. So our journey around health inequalities really started back in 2016 when we were approached by Growing Points, who are a small charity organisation who work with excluded communities, principally refugees and asylum seekers, supporting them into work. And we were approached by them to work with them on their Hidden Talents programme. So what we did was we supported the development of the programme through a very iterative process over a number of years. And what we managed to do was support 70 people into employment via apprenticeship roles over 6 cohorts. Now, our engagement with the programme was very much around helping individuals understand the nuances of an NHS organisation, helping them understand some of the language, the values and kind of expectations when it came to employment. Within Growing Points, they were a number of guardians that supported individuals throughout the programme of delivery, but also not just the programme delivery, but beyond that into the first 12 months post-employment. And the guardians are very much like mentors. So they are additional layer of support to help that individual settle into employment beyond their immediate line manager. Next slide, please. So in terms of lessons learned with this piece of work, as I mentioned, it was very iterative in the early stages, understanding kind of some of the complexities that individuals who were refugees or asylum seekers were experiencing. We were very aware quite early on in our process that we need to be careful around assumptions that we made when working with people from excluded communities. So understanding kind of both the unspoken word as well as the spoken word. And we recognised again really early on that one size doesn't fit all when we approach kind of our outreach or employability work, that we need to maintain that person-centred focus in order to maximise impact. Next slide, please. So moving forward, what we did was we took those lessons learned from our partnership with Growing Points, and we embarked on a targeted, geographically targeted approach to work with a community that sat within Lincoln Green. So Lincoln Green geographically sits adjacent to St James's Hospital, and at the time of our partnership was identified within the 3% most deprived ward within our city. So we developed a partnership approach working with employment and skills that sits within the Leeds City Council, and also again a local charity, Learning Community Partnerships, to develop a 6-week employment programme with the intention of supporting individuals into employment within estates and facilities. What we'd learned from our work with Growing Points was around comms and engagement and the use of language and being inclusive in our language. So we took that learning forward in this piece of work, and we developed a number of assets around communications, and not relying again on the written word, but developing a number of kind of animations and videos to kind of show some of the opportunities that were available. Throughout our work with Lincoln Green, we managed to support 50 people into employment, and 45 of them went into estates and facility roles, but 5 went into our nursing cohorts. And that was because when we engage with diverse communities, there is always hidden talents within that community. So individuals that have previous experience or qualifications, not necessarily within this country, but maybe within their country of origin, we were able to fast track them through into roles that suited both their skill set and preferences. Next slide, please. And again, what we pride ourselves on at LTHT is working from a place of lessons learned. So we're constantly asking ourselves, what are the even better ifs, and doing that horizon scanning piece. And what we learned through this targeted approach was when engaging with individuals or local communities, word of mouth is by far the most powerful asset you will have in your toolkit. So you need to get it right and get it right first time. Partnership working depends on trust. Therefore, you need to be really clear on what your end destination is, so you're not raising expectations and setting people up to fail. I think one of the biggest learning throughout this piece of work was organisational culture, and how that plays both is vital to accelerate progress within this area. If you don't take people with you, you can also limit your impacts. And what we also learned was the pre-employment programme was really good in the sense that it supported people get into work. It didn't necessarily support people get on in work. So it helped them be interview ready, but not necessarily work ready. And I think the thing to mention with the two programmes I've just described today is we didn't make any changes to process. What we did do is we front-loaded supports, but we didn't change any of our recruitment processes. And I'll hand back over to Jenny.
So next slide then, please. Thanks, Shell. Wow. So we decided not to stop there, and actually we didn't pause all the way through COVID, even though the next programme led by Leeds Teaching Hospitals did get paused, as you'll have seen on Shell's slide. We decided to think about how we were going to use the academy to scale up the learning from LTHT's experience and take that forward on a place-based wide approach. And I'm going to start from the right-hand side of this slide, because actually we've had three further sort of defined approaches to scaling this up across Leeds Place. We started by engaging our local mental health and community care trusts, working in partnership with the council. But actually now we just keep building on the experience of the work that we do in each phase. And we now have all of those organisations on the right hand of your slide there that are now participating with us in order to be able to provide opportunities for people from some of our most deprived backgrounds. If I then go to the far left-hand side of the slide, so who's it for? So we've broadened this out now. So you'll have heard Shell talk about sort of targeting either a geography or a particular disadvantaged group. But actually now, throughout the cohorts, we've been able to scale that up to be much more inclusive, but still targeted of those that need our help the most. What we're really proud of as well is that we've moved further on from job employment opportunities to also bring in not just entry-level roles, but more experienced jobs, and also then to be thinking about the opportunity for people to be able to connect with volunteering or further training and education. So you can see each time we grow confidence in this space, we broaden out, but in a very thoughtful and evaluated way, what's worked, particularly as a city, and what do we want to hold on to and where do we want to go next. And you'll then see the sorts of careers that we have also been able to broaden out. All of that now is handled by what we call a sort of a hub and a spoke model. So very much a Leeds model now, rather than an LTHT initiative led by a single provider within a place. And really importantly, we just continue to test what we do, that proof of concept, and then take what's worked into the next phase. And that gives us the confidence to be able to go further. And in fact, only a few months ago, we sort of pulled a thought leadership piece together to say, so what do we do next? And actually concluded it was a lot of more of the same, just deepening our efforts and slightly broadening our efforts, but nothing radically different. So if we can come on to the next slide, just to be able to see just some of the impact now on top of the statistics that Shell's given you. we've done quite a bit of work, and she'll be able to tell you more about this, around flipping the recruitment model. But that's meant that taking the learning from Growing Points and Lincoln Green, where we know we've got to help people understand what it really means to have a job and a career opportunity within health and care within the city. It's really important that we help people understand what they are joining. But we're proud of the fact that of all of the people that we've recruited into city roles, we've got a retention statistic of 95% at that 12-month point. We're sharing the slides, so we've given you quite a lot of data. I'll just pull some of these out so that you can, you can read rather than me run out of time. So we've 166 people supported into employment. 86 of those are from a non-British white background, and 58% of them have been unemployed for more than 12 months. So again, really pleased to have helped that disadvantaged group. And was just thinking about those that are in unemployment, and the link very much to Kathy's slide around wanting to make sure that we're supporting children to grow up in a family that has got a much stronger and a healthier income. Interestingly, there's been some byproducts. So obviously we were working through COVID, and it meant that at the same time as talking to our communities, we were able to encourage them to take the COVID vaccination. And because of our work at place rather than as an organisation, we are attracting quite a lot of interest, and therefore with interest often, you'll know, comes some help with some external funding. So I'll just go to the next couple of slides and then we'll open it up for some questions. Please do have a look at this video. This is an absolutely brilliant story. This is two colleagues, first of all, who joined us through the Lincoln Green part of our work. That's right, isn't it, Shell? I've got the right stage, yeah. And John and Bernadette came into our estates and facilities roles. Bernadette was very pregnant. She was just about to have her child, but we worked really closely with them, supported them both into work, and actually Winnie, now their eldest daughter, has also joined the trust back in the autumn last year. So have a look at the video. It will bring their story to life way better than I can ever do it justice. Next slide, please. So some key messages for you, really. It's definitely a marathon and not a sprint, and we really have put a lot of effort into understanding what works and doesn't work. And we've learned a huge amount, I would say, along the way. And therefore, I'll jump to the third bullet point, actually, building this with our communities and not for them, because actually, I would argue that they know better than we do in terms of what is going to be most helpful. Investing in our community partnerships, and very much the last bullet point on there about mapping agencies and initiatives. We've got through the Leeds Health and Care Academy, because it's place-based, way better connections with a much larger group of organisations, all of whom, like us, are trying to achieve the same thing. But bringing all of those together has proved to be enormously valuable, and really helped us to all sort of pull in unison together rather than all doing that separately. And of course, what you've heard peppered throughout Shell and my examples are, we really have been trying to work with just sort of root cause and make some changes that really are going to get to reducing health inequalities. And the learning has been enormous, I think, as you will see. So we'll leave you with some slide with just some places to go to. We've written up some of our work through case studies, but there's some other helpful reference points there as well. And although we've skipped through the slides, we've deliberately put quite a bit of information in there so that people have got it to refer to afterwards. So thank you for listening.
Thank you so much, Jenny and Shell. That's, a fantastic demonstration of really being an anchor institution within your community, and also building that pipeline into the NHS. I guess just a little reflection from me is that we know from the RES data that those who are from Black and ethnic minority backgrounds are often in the lowest bands within the NHS. And as a woman of colour myself, I've sat in many executive roles and often been the only person of colour. So how do you see us being able to transition some of those people who, you've had an amazing connection with through into leadership and management, so that we can actually see the change happen across the whole sphere of the NHS and not just within the sort of apprenticeship and lower bands of working?
Agreed, Marianne. I think that's crucial, and it's one of the big reflections that we're worried about in our early work. So we've worked really hard to make sure that when helping people to join through a variety of routes, that there is a career path, and that we've tried to remove as many of the barriers as we possibly can to somebody coming in on an entry-level role still being able to see a career all the way through to board level. So we've worked very, very hard at that, particularly in the NHS, where I think we've got more ability to be able to do that, I think. But we are also trying now to attract into some of the more senior roles. That's the piece we're focused on now, in order to be able to try and accelerate some of that. But it's a really crucial point. But we always talk about careers in health and care rather than just a job in health and care.
Yeah, that's fantastic. For those who've got questions, please put your hands up or put your question in the chat box. We'd love to hear it. Another question that I had was just around impact. So how you're measuring the impact of what you're currently doing, and then also in terms of your target. So what are you aiming for, and is that a big enough stretch? Should we be more ambitious?
So I'll get Shell to join in. We've just actually recruited into the academy a researcher, because we think this is far more important than just the numbers. And one of the pieces of work that our researcher is going to do is some of the longitudinal work and just study sort of the benefits and track individuals that we are working with. So that piece is yet to be scoped by our researcher, but they join us this month, I think. So really keen that we talk more broadly than just pure numbers. That's a great question about target, and we don't have one actually, Marianne. So I really like the challenge in there. You can tell we've been very experimental and incremental, but we are at a point, actually, you're right, where we should be thinking, what is it that we're striving to achieve? So appreciate the challenge in there. Thank you. Shell, I don't know whether you would want to add anything to the questions at all.
Yeah, just to add in, this piece of work isn't in isolation. So within the Healthcare Academy, we're also doing a piece of work around interacting and engaging with young people to kind of raise aspirations. So we recognise the interdependencies between, a family member having good, solid employment and the impact that has on young children, particularly when in deprivation. We're also focusing our efforts on working with those children between the ages of 4 and 16 to raise their aspirations and also identify alternate routes for them to secure a career based on both their ambition and preference. So recognising that traditional methods of education, i.e. GCSEs, A-levels, isn't the right fit for everyone, but trying to level up by engaging with children as young as 4.
Wow, that's great. Really good to hear. We've got 2 questions before we wrap up. Sharon, can I bring you in to ask your question, please?
Yeah, the flipped recruitment model sounds really interesting. I think that'd be really advantageous. Have you applied that to all job kind of spheres, or has it mainly been nursing, clinical kind of stuff? And secondly, apart from training, what else have you done within that model?
Do you want me to pick that, Jenny?
Shall you go, because this is your
So flip recruitment model is simply as it suggests. So it's giving people the opportunity to undertake simulated practice within a classroom or safe space aligned to a particular job. So we have 2 successful pathways that we've embedded into a BAU model now, and this is supporting people into careers within care. So that's your healthcare worker, clinical support worker, via direct entry or an apprenticeship route, depending on that individual's preference and ability. And also customer service, so your kind of admin roles, because both those roles are applicable across the full system rather than within one organisation. So what we're able to do now, because we have that proof of concept and we've got some really strong evidence in terms of the impact, particularly on the retention aspect of this work, we're working with more diverse partners to develop similar models. So providing training up front to give people that opportunity to identify whether the job is right for them, but equally kind of shift that culture in terms of recruiting. So we often talk about person-centred care, yet our current recruitment model doesn't allow us to apply the same principle, because we shortlist against someone's ability to write against a job description, and actually viewing them through a period of time, whether that's a week or 4 weeks, through a kind of a pre-employment programme, allows us to view that person holistically and identify their strengths, and then for us to kind of match where our opportunities are available to help them achieve their potential.
That's great. Thank you, Shell, for that. And our last question is from Lizzie. And Lizzie has said in the chat, can you help me to understand how the great work being done by the Health and Care Academy is impacting on health inequalities and how you're measuring that impact?
So we've got some great anecdotal stories, Lizzie, really good stories. But we're not systematically measuring at the minute that impact on health inequality, which we'd love to do, which is why we've got the new researcher joining the team, because that's the piece that we really, that's the bit that we need to do next. So we've got some great case studies, but it would be brilliant, enough really to be able to help us believe that we are making a difference, but we've got absolutely no idea at this point in time what that is, I would say. Shell, do you think that's fair? And therefore we work with the case studies, we work with the informal feedback, but we do want to capture that impact, and that's what our new researcher will help us do.
That's great. Lizzie, does that answer your question, or did you want to come in and add anything?
Well, it doesn't answer my question, but I absolutely understand why it doesn't answer my question. So thank you for your honesty.
Yeah, thank you. It's a really difficult one, isn't it? Measuring the impact from a qualitative and quantitative perspective on some of these really complex problems.
And I suppose, because I absolutely think what's being done is absolutely brilliant, and I really would want to strongly advocate for that model. And it will be making a difference to those people in the sense of their employability and their the quality of the life that they can have now and into the future. But how you connect that to health inequalities, I think that's a big step. I'm not saying that we should be doing it. I just think that's a big step to do that.
And I think it was good, Jenny, that you mentioned about bringing research in, because I think this is the space where research and the academic health science network that I work for can really bring in some of those insights, and also ability to evaluate and look at the evidence base that's already out there that perhaps we're not applying. So yeah, really interesting. So thank you so much, Shell and Jenny. Really appreciate you taking the time to speak to us. And we will move on to our next presenter, who is Rob Aitchinson, and he is the Deputy Chief Executive at Calderdale and Huddersfield NHS Trust. Over to you, Rob.
Thank you, Marianne. Good afternoon, everyone. Really pleased to be here with you, and a big act to follow those 2 fantastic presentations. So I'll try my best. So as well as my kind of main role here at the Trust, I'm also the Trust Lead for Population Health and Inequalities. So it's been a really interesting area for me to be involved in, and I think the kind of the main learning for me really is the amount of interest there is in this subject and the enthusiasm that we can really kind of build on to do some great things. So I'm going to talk today just about the different things, a few kind of samples of things that we're doing at the Trust. I'm happy to pick up any of these areas in a bit more detail, because some of them are just getting a bit of a mention before I move on. So I'll kick off then. So just really to talk first of all about where we started from in the organisation on slide 2. This is really where we kind of started talking about inequalities in a much kind of more meaningful way. And you can see it's fairly tiny there, but January 2021, this is when we first had a look at the waiting times for treatment. And I'm sure many of you will have seen some of the work that we did within the organisation at that point to highlight the differential between care and access to care. So this is patients who are waiting for priority 2 treatment at this point in time. And this was very much demonstrating the IMD differences, so our kind of most and our least deprived communities. But in addition to that, we also saw the same pattern from a kind of an ethnicity point of view. So really started from a point of view of a really clear platform to do something different and to understand what was driving some of those differences. And that, like I say, was the platform for a much better conversation in the organisation. So we kicked that off, and obviously you can see this graph extends right up to the present day, and this is something that we continue to look at and to monitor ourselves against. The little table at the side there, I'm sure you've all got exactly the same difference within the places to a greater or a lesser extent that you support. I've seen previously in my last organisation I worked, we had a kind of a bus journey which demonstrated really nicely the real differences that are in all of our communities, from the kind of the most to the least deprived areas. We use that quite regularly, and it's a really kind of stark reminder of the differences that are out there. So I'll move on to my next slide. I'm going to just give you a specific kind of overview of 3 things that we've done in a bit more detail, and then I'm just going to just highlight a few other things that we're currently working on. I think the important thing to say is that it is a bit of a journey, isn't it? The work around inequalities and population health. Some of the things we're still working on, and we're still scratching our head around how we do it. So I'll share some of those with you, and there might even be some helpful feedback that I can take away here. So this first one, I'll be careful after that fantastic presentation we just had from Jenny and Shell, but I think from a workforce perspective, one of the things that's been really key for us here is to understand some of our data, and I think we've really benefited from some fantastic informatics support in the organisation to be quite conscious and aware of the work we're doing and the impact it's having. So you can see from this slide here, the work that we've done around particularly apprenticeships into the organisation, doing lots of targeted work with certain specific parts of our community. And we've developed some really great links with local groups and education providers, and really kind of wrapped around that single purpose of trying to drive up representation from some of these communities. So you can see here, there's a couple of, I think, really impressive kind of figures in here. You can see the 84% of people who are progressing into apprenticeship roles coming from the 3 kind of most deprived communities. And then similarly, you can see the representation around the age band and kind of gender and ethnicity. So some really pleasing work there. There's lots more work that we're doing on this, and probably just important to make the point that all this information goes through to our various committees. Our workforce committee look at this on a regular basis. So really helps to kind of tell the story of the work that we're doing. I'll move on at a pace then. The second thing I just wanted to kind of highlight and bring to your attention, on this next slide. This very much was work that we did during COVID, and really it came out a little bit like the waiting time work that we did. Came out of the pandemic ultimately, and certain parts of our communities were suffering worse outcomes, as I'm sure you're all aware and have kind of lived and breathed really. So we worked at place level, so our Calderdale place, which is one half of the communities that we serve at Calderdale and Huddersfield. And we focused particularly on those that were in high-risk occupations, so including taxi drivers, independent shops and care homes. And we did a kind of real balance of different things here. So one of the things that we did was we supported PPE to those kind of communities and those parts of those sectors. And we also did lots of work around education, involvement, and particularly around vaccination kind of education. I think the really crucial bits to this piece of work was that we did it together as a system, which I'm sure you're all doing within your respective places. But the other bit was around the engagement with community champions. So rather than us coming to it with preconceived ideas around what mattered to communities, we engaged really closely and early on with key people in the different communities. I've just included there a really nice 10-minute video, which actually is worth a watch because it tells the story really well from a kind of first-person perspective of kind of how the key parts of kind of success for that piece of work. So please, if you get a chance, have a quick look at that. It's well worth doing. I'll move on now to my next slide then. So this is, when I talked about at the beginning, kind of things that we're still scratching our head over at the moment. This is definitely one of those things at the moment. So particularly kind of maybe 6 to 12 months ago, there was a lot of discussion nationally in HSJ and things like that around prioritisation tools and how we should take not just a clinical perspective to prioritisation of patients for treatment. We should also look at that kind of social kind of background, the conditions that people are kind of facing in accessing care. And so we've developed a vulnerability prioritisation tool, which is a bit of a mouthful, granted, but there are some really interesting bits coming out of this. So we've used these core metrics, which are in the bottom left-hand side of the slide here. They are going to be in kind of every flavour of this because we think these things are really important. But what we've also tried to do with this is to give individual areas the ability to kind of flavour this to the things that it thinks important within their specialty. We're still kind of playing with this, is how I would describe it at the moment, but we're just about to go live with our prehabilitation service for cancer. So this is people who are confirmed cancer cases, who are just about to undergo quite significant treatment, chemotherapy and things associated with it. It might be surgery actually as well. And we have effectively, we don't have the full capacity, nor would these people all benefit from the prehabilitation service. We're trying to find those people who would most benefit from nutrition advice, maybe exercise advice in advance of their treatment to make sure they're fit enough for the surgery or treatment. And we're using this vulnerability tool now for that first group of patients. We've got aspiration to move on to other groups, one of which will ultimately probably be surgical care. But we're still grappling with how best to apply this at the moment because it, for obvious reasons, it's quite complex. So we're certainly not saying we're doing this at the moment for that group, but it is something that we're continuing to explore with our clinical teams. Okay, I'll keep going then. So then the next slide gives just a bit of a flavour of the things I didn't want to leave out, if I'm perfectly honest with you, because we're really, really proud of some of these different aspects of the work that we've done. So looking at the question of what does a community-led response look like, these are all things that we've done which I think have a significant impact. So this graph on the left-hand side here, what this graph is showing at the moment is the blue line is patients with a learning disability flag. The red line is people who are just not without an LD flag. You can see when we started this work, the real focus around this group of patients, again, similar time to that last graph I showed you, the wait time for learning disability patients was significantly higher. Through the work of our team inside the trust and significant amount of kind of highlighting the importance of this and setting ourselves some standards to work to, you can see the blue line now is consistently below. So our patients with a learning disability flag on our system are getting significantly quicker treatment. And I suppose the obvious question is, how accurate is that in terms of us understanding who those patients are? We've got to a point where we have quite a high degree of confidence that we're identifying those patients as they come through the hospital. Lots of work with primary care and others in the system. The middle picture there is a service we've developed called the Blossom service. So this is effectively a signposting service that works in A&E. In the first instance, we've targeted it around young people, kind of age 16 to 25 roughly. And we are signposting them out back into community services that can meet their needs in the longer term rather than just that acute need when they present to the A&E department. And then the one on the right-hand side there, a lady called Sarah Wilson there, who's our community matron. She's set up really from an interest and kind of the type of people living within the part of the community that she serves. We've set up a pop-up clinic, and this is typically people without a fixed abode or a kind of serious addiction, either alcohol or drugs. And she set up this clinic once a week. It's become a bit of a word of mouth thing, so they can potentially support 70, 80 people on that caseload through that clinic. The real key that she's been kind of focusing on, Sarah, and the people working with her, has been trying to fix some of the things that are holding people back. So again, I'm sure lots of you on this will know pressure ulcers, that ulcers and things caused by addiction, significant kind of things that stop you then trying to access other care and ultimately trying to find a way out of that addiction. So Sarah set that up. It's going fantastically well, and there's lots of other teams and services that wrap around that. Okay, so I'll keep going. So then this next slide really is the bit that's kind of led us up to here with the bits I've just described. So we November last year, we signed off a population health and inequality strategy for the trust, thinking about that link back to the board, and not just executive colleagues, but non-executive colleagues sitting on the board. This has been a really important tool for us because it's given us something we keep coming back to. We can continue to talk about our strategy in a way that we're all consistently describing, and we know where we're heading. So hopefully helpful. We've split it into these 4 different quadrants because I think that best reflects the different types of work we're doing. There's a little bit of an internal focus to some of this work, but also obviously the exam question today around communities. You can see there's quite a significant amount in there that's focused around what we're doing with our communities. And then just on this last slide, just to kind of pull things together, I guess in terms of key learning, we've really benefited from some good support so far in the organisation. So I've mentioned informatics support. We've also had a public health consultant working in the organisation on placement as part of their registrar training. Rachel's role has been really, really crucial, and she's helped educate us. She's helped us kind of skill up on some of this and to bring a real evidence base behind some of the work we're doing. And then the other role I would call out specifically is the learning disability role. So we've got a nurse consultant role in the organisation called Amanda Mackay. She's been fantastic in terms of advocating and educating us on the work that we need to do in that regard. So my kind of tips really for anyone wanting anything to take away from this is just looking for those early wins. So there's what we've found as we've developed this work and started to talk about this in the organisation, there are lots and lots of areas that really want to do this work and they really want to make a difference for the groups or the communities they serve. It can be quite hard to kind of have a handle on this work as a trust level because there is so much going on, but getting the kind of people to the group and helping them to be involved and then letting them go with it, I think has been really key for us in this work happening. And then I think that the key thing for us, we have had 3 or 4 really specific projects that we've continued to work on and that we've kept coming back to just to be able to demonstrate some of the progress that we're making. And then just to cheer anyone up if they think, well, we haven't done a great deal or there's more to do. This is our current project. So this graph here on the right-hand side is DNA rates. And I don't know, for me, it's one of those graphs that makes you fall off your chair, really, because we think we're making progress with a number of these things and we think we understand the issues. But to keep reminding ourselves that our current did not attend rates for those from our kind of our highest IMD groups is 10%. Once you strip that group out, it's less than 4%. So we know, and we can all talk about the reasons, but until we do something about and support some of these people to get to the hospital and access the care that we want them to receive, I think there'll be more to do. So we're looking at lots of different things at the moment. Some of it is around how we contact people and how we identify the things that are barriers to them accessing care, but we're also looking at alternative transport and other ways that we can support people. I think it's really important that we don't disempower people by telling them what we think they need. We need to talk to them and we need to understand some of this, but it is pretty stark information. So lots more to do. And that's all I was going to do, Marianne, if that's okay.
Thank you so much, Rob. That was a really, really interesting presentation. And I love your, strategy on a page for population health inequalities. And I think it's so important that you do have EDI with what you're going to do around health inequalities or health equity. I just wonder if you can expand on that. Why do you think that's important? Two elements that have kind of sat away from each other. So, health inequalities is sat in population health and ED&I has been sat kind of with people and culture. Why is it important to bring them back together?
I think, we've probably talked about this for a while, haven't we? But I think, we know we've got a really, really diverse population in our kind of local community. So we've got Calderdale and Kirklees, both have kind of different things going on in them. And I think the language that we would use around having a workforce that's representative of those communities, I think you've seen it through that COVID example, is really key. But I think for us, the other thing that we've done, we're really trying to give those EDI networks real profile in the organisation so that people feel like their voice is heard and feel like it's representative of the things that they experience. But also it just makes really kind of sensible sense, doesn't it, to make sure that you're getting as many different perspectives and that you haven't got any blind spots in the things that you're doing as an organisation. So we talk about being representative. I guess your challenge earlier, Marianne, is the right one. Is representative almost enough? And I'm not sure it is in some respects because we're playing catch up. But I think we're trying wherever possible to have like you say, a joint conversation about the two.
Yeah, thank you. And with your strategy, what are some of the ways in which you've socialized that? I guess both from your, your staff and colleagues, but also in terms of your patients and community. How does everyone know about the strategy, and what are their thoughts in relation to it?
Yeah, no, it is a good question. No, not everyone does know about the strategy, and I think where I take a bit of heart from this, and so coming into the organisation and trying to, like I said earlier, trying to make sense of this, and my previous background as a chief operating officer, and some of that would be a bit more structured in my head. This is a bit more strategic, and it's trying to find a way to harness all the enthusiasm. I think it's okay that people don't all know about the strategy. We'll put it out there and we'll advertise it, but actually, when I speak to people, and the point I was trying to draw out about people's willingness to be involved, everyone wants to be kind of, having a kind of a role in driving this work, because it's really crucial and important. So the other week, there's a piece of work I wasn't aware of in therapies, where the team had sent me some information. They'd grabbed the tools around segmentation by IMD, and they talked about the differential in the wait time, and thought, yes, this is great. I haven't even been involved here, and people are getting on with it and doing things for the right reasons. So there is a bit of that kind of, what's the phrase around the different flowers growing 1,000 flowers. There's something about letting it happen once you put in the support in place for people.
Yeah, thank you so much. Karen, I can see your hand is up. Would you like to come in?
Thanks, Marianne. Thanks, Rob. Absolutely brilliant presentation, and actually quite inspirational, and quite exciting. I was wanting to ask you about community engagement. I mean, what have you done in terms of community engagement? I mean, Marianne talked a little bit about socialising that strategy on a page, but I'm really interested. It's quite challenging, I think, about how we actually engage meaningfully with communities, not just telling them stuff, but actually really taking stuff on board and understanding what communities need. So I'm just interested in your experiences, really.
Yeah, so there's plenty more to do, I suppose, is probably the main take home. I think one of the things that's been really key has been really closely working with the local authority. So we've got a number of voluntary sector groups, so we've got a really kind of active group both in Calderdale and Kirklees, and really good leadership. And one of the big take homes for me was understanding the person in the local authority who does the job probably most similar to mine, around what networks they've already got that exist. So coming together with so I'm very kind of NHS in my education. So coming together with the community neighbourhoods lead for the local authority, who had lots of existing links already in place and was doing quite similar work. We've tried to target some of the work within some of those specific areas where we know we've got the kind of the most challenge around inclusion and representation and all those kind of bits that come with it. So it's definitely not cracked. I think the work that we did during COVID that I've highlighted today, people are really, really proud of, and we've managed to hold on to some of those relationships. And then the other thing we've done, which is a bit of a trial, is...
We lost him. We might come back to Rob. He might have some. We lost you, Rob. Your internet went funny. We lost.
Oh, I'm sorry. Should I repeat? Sorry.
We only lost about the last minute. So.
Oh goodness. Sorry. Sorry, Karen. I'll be brief for this time. So we have done lots. Did you get the bit around the local authority, Marianne? Yeah. Okay. I'll stop there then. But I'm happy to pick up Karen offline if there's anything else.
Thank you so much. I think we're going to move into the panel discussion now. There are a number of questions in the chat box. So thank you for joining us for the final part of our webinar. So there's a question here from Swanjit Singh. Have you embedded the use of Core 20+5 metrics for adults and children to show improved outcomes? And is the local ICB commissioning appropriately to address the health inequalities on its patch, e.g. autism, ADHD assessments? So who would like to take that question? So really just how have you incorporated the Core 20+5 into some of the strategies that you've been doing? Rob, that might be one for you.
Yeah, I'm sorry, I was looking for my hand. Yes, so the Core 20, Yes and no, I would say. So I think in some respects we've focused on areas like access, for example, which does run through quite a lot of that core 20. I think if I was answering the exam question on this, I would say we have, because kind of the IMD and the different kind of segmentation of groups, it's just absolute second hand to us now. We use it for everything that we're doing in the organisation. In terms of some of those extended service specific things like kind of heart failure, things like that, we probably haven't done as much on that at the moment specifically. The ICB question, I think, is a tricky one, because actually we know across some of those areas, I think where the inequalities are exacerbated is in the first instance when there's challenge within those services. So the ADHD one, I would say absolutely we're not done on that one by any stretch at the moment, because it's a really challenging area anyway. Is there a focus on it? Yes. But no, I would say that's absolutely not done.
Yeah, I think we're kind of at the beginning of that journey, aren't we? Lizzie, I can see your hand up. I'll bring you in.
Thanks. This is a question for Rob. I'm curious. I don't know much about your trust. Is it an integrated trust?
Yes. Sorry.
I thought it might be.
Yeah, we provide community services within Calderdale, and then we work with partners in Kirklees. But ultimately, yes, we're integrated. Because
that really must be the vehicle through which you're able to do all of that work that you've been doing so well in the community and engaging with community champions. And I think that if you're not an integrated trust, if you're an acute trust, it begs the good relationships that you develop within your place arrangement with your community providers, really, doesn't it?
Yeah, I think you're right, and I don't want to kind of underestimate, I guess, the input that the impact that we've had of having both ends of it. I think in Kirklees we work with an organisation called Locala, who are fantastic actually, and I think some of it's almost working out what we each bring to that kind of the work really. So on the Huddersfield side we have the kind of hospital doctors type approach, and they've got the community element of it. So we've managed to come together on quite a bit of that, but. If I was being really honest, the community clinic that I mentioned, I'm not sure if we were in the Calderdale place, wouldn't necessarily that would have come about in the way it has so far.
Thanks. Jenny, I can see your hands up.
Yeah, I was interested in Lizzie's question, because I think there probably is an advantage about there being an integrated trust. However, I still don't think that's broad enough, Lizzie, because if I just think about the work we've done as a place in Leeds, we've dozens and dozens of partners now that we are all working with, and they're feeding back to us that actually having a single place within the city within which they then all connect has been hugely valuable. And I'm not sure that us operating purely as the NHS particularly helps our partners. So that integrated, a place-based approach, I do see the benefit. I'm sure Rob will feel it in the work, but I just don't think it goes far enough.
Yeah, lots to do. Lizzie, did you want to come back?
Yes, I just wanted to say I absolutely agree with you. I don't think the solution is that we'd all become integrated. I think what we need to do is to make sure whatever we are within the NHS is that we work with that real diversity of partners that exists in your particular place. And everybody, as Rob said, everybody understanding what they bring to that relationship and what they're asking from that relationship.
Yeah, definitely. Thank you so much. A really great question. I'll just take one that's off the chat. So Khadija Begum has said, great overview, Rob. Do you have a contact for the vulnerability prioritisation tool? How does this work in terms of waiting lists? Do some people who are more vulnerable, for example, IMD 1 get pulled up ahead of those IMD 10, for example, who may have been waiting longer? Yeah, can create some interesting practices, can't it?
Yeah, and I again, I'll be brief on this. You're absolutely right, though, Maria. I think we've held off at this stage for that reason. I think there is something in there that I suppose the key thing is it needs to be usable by everybody that's involved in this. So the minute it becomes too complex and too kind of the computer says this or this, I think we'll have lost the fight on that one. So the reason we've started within the cancer prehabilitation is it's quite kind of linear and quite clear around how we would apply it. I think it's probably still worth having a go at longer term to see whether or not there's something we can do in other areas. We're working with our EPR provider Cerner to see whether we can do anything there as well. So I'm more than happy to share Callum McIver's details with you, Khadija, and I don't know, Marianne, if whether there's anything else we want to do wider than that. I'm sure he'd love to show people. He's very proud of the work he's done.
Yeah, I think it's a really tough one, isn't it? I think we're constantly looking for a quicker solution, something that's easier to do. Oh, it's a check, but it can become tokenistic, like a checklist, when actually, you know, perhaps it's to start a conversation with an individual who's vulnerable so that we can actually go through some of their background and history and have more detail to then make the decision in relation to it. I think sometimes we can just be a bit too simplistic about people's circumstances or background and, you know, what their needs might be, rather than taking that bit of extra time to really talk to them and understand them.
No, I think you're right. I think one of the things that I really kind of learned myself was that when you look at what the prioritization tool is doing, the people who are at the top of that list, I think objectively, most people would say, I want to lay hands on that person now. So regardless of their clinical condition, there is a severe need there. So there is a real complexity to that patient. And if that patient presented an ED, they would probably get a different pathway of care. So I think there is definitely something that's worth still continuing to do with that area.
That's great. Thank you so much. Karen, I did see your hand was up previously. I think your question might have been answered, but did you want to make a comment anyway?
I was just going to come in on the integration point, because I'm the chair of a community trust. So I think you've got the representative of all different types of trusts on this call. And actually, I don't think it matters what the organisation is. It's the culture and the way we work together, not just in the NHS, because actually, you know, we've talked about how actually it's a small impact we have on health inequalities, and actually it's local authorities, it's GPs, it's community groups, it's faith groups. So it's having that open-mindedness as NHS providers, and not being, you know, holding on to our organisation and being. It's really, really important that we have that mindset. So I think mindset's much more important than organisational form. And that's all I want to say.
Completely agree with you, Karen. I think that, you know, going back to something Sharon mentioned before, so how do we start to change the hearts and minds? Because we're all very engaged and committed on this call. That's why we're here. But how do we change other people to come on this transformation journey with us? Because as Sharon said earlier, you can't just leave these pieces of work to those who are from the minority background. It's too hard, it's tiring, we get burnt out. So how are we going to start to leverage the majority to help the minority? Who would like to answer that question? Go for it, Jenny.
I think that's the absolute key. So I'll talk from a staff perspective rather than from a service delivery perspective. I think that I will always on a Monday morning, every Monday, personally greet. I know we're a large organisation, but we will often onboard anything between 50 and 100 people in a week. And I will always personally join them and set the expectation of them to step outside of their comfort zone and to be able to be a proactive part of helping our organisation to be fully inclusive and free from discrimination. And then in induction, we go on to describe for them the things that we've got available, all of which we've talked about today: reciprocal mentoring, amazing networks. We published a book about some of our staff's stories. We give everybody a version of that book on joining the organisation. We have a model for inclusive conversations, which we are rolling out across the organisation, but not as a rollout. So we're working with local leaders where they're beginning to identify either a challenge or an opportunity, and we will take the conversation model into those places rather than just mandating a set of inclusion conversations across the organisation. But we have the ambition that all 22,000 staff in our organisation will have participated in something at least once. But the avenue toward to doing that is very varied. So it's not one thing but it absolutely, and we can de-bias our approaches, we can do all of the work that we've been doing, you know, we've heard today, but if we don't get everybody to understand, and I love the fact that we've had some really difficult conversations in Leeds. I've had a number of clinicians really push back about terminology like white privilege. And of course, that gets you into a really healthy conversation then. So it's not to shy away from those, I would suggest, and take absolutely every opportunity that we've got as leaders to be able to, and you know, find the space for those conversations.
Thank you so much, Jenny. Really important. And I think that, you know, as we strive to work towards being anti-racist organisations, you know, we're going to have to get comfortable with being uncomfortable with those conversations, because they are challenging, but we need to have them. So, yeah, thank you so much, both of you, for coming today. Your presentations were absolutely fantastic, really thought-provoking. And, you know, I hope that people have gone away with some ideas perhaps that they might take to their own organisations. If you have any other questions, please don't hesitate to contact us, and we'll hopefully be able to get some answers for you. Please scan the QR codes and access the link to the chat to book any upcoming events. We really would like you to complete our evaluation form, so please click on it. It takes about 5 minutes to do. And, you know, we'll be doing a number of these events over the coming months around health inequalities. So, you know, a fantastic opportunity for us to continue this discussion moving forward. So thank you very much for everyone that's participated, to our speakers again for agreeing to participate in our session and for lending us their time and expertise. So thank you, and goodbye. Have a great afternoon.